Hello everyone and welcome to today's program. I am Bassam and I am honored to be joined by Dr. Kamran Aghayev to discuss a rare but very important condition, Eagle syndrome, and its connection to jugular vein compression. Dr. Aghayev, thank you for joining us.
Thank you, Bassam. It's great to be here.
So, Doctor, can you tell us about Eagle syndrome? What is the background about Eagle syndrome?
Well, it's a very interesting disease. It's not as rare as most people assumed. And by saying most people, I mean most people with a knowledge of matter, people who knows this disease. It started in 1930s and 1940s when an ENT surgeon from the United States, Dr. Eagle, noticed interesting thing. He saw some people after tonsillectomy getting pain in the throat and difficulties with swallowing. Sometimes those people will get pain in their head, in their face, and all different symptoms, in their neck and face and head, mostly related to the pain. And he noticed that most of these people feel like their pain started right after the surgery and was somehow related to surgery after tonsillectomy. One thing he noticed about those people that they had quite long bone protrusions that we call styloid processes. So for those who are unfamiliar with what it is, styloid processes are extrusions coming out of the skull base from the temporal bone, technically. They're projecting down like stalactites in the cave, and they serve as an anchor for several muscles and the ligaments. And in some people, they can be quite long. Normally, they're about like a 2.5, maybe 3 centimeters, but in some people, they can be quite long. And Dr. Eagle actually made a link, which was correct at that time, that when the styloids are too long, they cause problem. But they may cause problem on their own, but sometimes the problem may be caused by tonsillectomy, removal of the tonsils. And he was the first one who pointed to the problem, and that's how the syndrome actually was named after him. So it has nothing to do with the birds, with eagles flying in the skies, nothing like this. It has to do with Dr. Eagle and his legacy contributing to this disease. Later on, we figured out that Eagle syndrome, or what we call today Eagle syndrome, is much more complex and much more broad disease than was initially thought. So now we talk about vascular Eagle syndrome as a variant of Eagle syndrome, when the artery, carotid artery, or the jugular vein, which are nearby the styloid process, may somehow get compressed or stretched or kinked in a vicinity of the styloid process. Sometimes we see the nerves that are in the vicinity of the styloid process. They are compromised and may lead to some neurological problems. So now the term Eagle syndrome had broadened, and now the way I would like to call it is atlantostyloidal compression syndrome, because as the disease evolved, we figured out that one of the most important contributions comes not from the styloid process itself, but from the C1, which is called atlas. So the term atlantostyloidal compression syndrome is probably a better term than just the Eagle syndrome, which is sometimes used just to denote long styloid process.
So, as we understand from you now, that this disease, it's not just from the styloid process. It
That's
can
right.
be also like jugular vein compression from C1. So,
That's right.
what is the method or surgery methods to solve this disease or to treat this disease?
Well, here it is. The only solution for this eagle syndrome or a vascular eagle syndrome or a atlanto-styloidal compression syndrome or ASCS, as I call it, is surgery. So there is no conservative treatment, first of all, to start with. And surgery is very interesting because back in 30s and 40s, Dr. Eagle himself, he advocated removal of the styloid process, but he advocated removal from the mouth, from the tonsillar fossa. So as if the doctor was doing tonsillectomy, he would go into the tonsil area, make an incision, find the tip of the styloid process and remove it. And that was basically the treatment for the styloid, for the long styloid processes for a long time. But later we figured out, that the disease or condition, let's call it, is much more complex and much more broad and associated with compression of the nearby vascular structures. So we figured out empirically by trying and erring that styloidectomy alone is not sufficient, and in most cases is not sufficient. First of all, when you do styloidectomy from the mouth, you do not remove the styloid process completely. You just remove the tips of the styloid process. So it's incomplete resection. You can remove the styloid process through transcervical approach, that is making incision in the neck, on the skin, and approaching the styloid process from below and removing it. And that's how another group of surgeons started to use this procedure. But later on, we figured that actually, in the vast majority of cases, the cause of compression, the cause of the problem, is not coming from the styloid process itself. So styloid process is somehow involved, and this is the matter I would like to explain in detail later on, but it's coming from the first cervical vertebra, namely C1, or atlas as we call it. So atlas is the first cervical vertebra, is right beneath the skull, and it's mobile in relation to the skull, and in some cases atlas is shifted to the front, forward, and by this shift the atlas may push all the structures that in front of it forward, and the most close structure to atlas is the jugular vein. In fact, the jugular vein runs in between the atlas and C1, and atlas pushes the jugular vein forward, bends it, kinks it, and in some cases pushes it against the styloid process. And that's why the styloid process is important. So it's passively sitting there while atlas is pushing the internal jugular vein forward. This push may be constant or may be dynamic when we turn our head right or left, and atlas changes its position regarding to the skull base and maybe pushing jugular vein more or less, with head motion. Nevertheless, the main issue is atlas here, and we figured out, and this has happened in the last 10 or 15 years or so, that in order to achieve successful treatment, and by successful treatment I mean decompression, taking away the pressure from the structures, can be done with the removal of the part of the atlas, the part of the atlas that is pushing the jugular vein or other structures
forward. Do you mean
forward.
without removing styloid process?
Even without the removing styloid process, very interestingly, there are papers, there are publications, scientific publications that basically show that resection or removal of the part of the atlas, that part of we call transverse process or shaving off, you can call it whatever, but we just removing the portion of the atlas, small portion of the atlas that is pushing the structures forward, may be sufficient even without the removal of the styloid process. But if you do both, if you resect the styloid process aggressively all the way to the skull base, from its origin all the way to the tip, and you resect the transverse process of C1, then you get the most benefit out of the procedure.
In your mind, like if you remove both of them, all styloid process and shaving C1, so you don't leave any chance to jugular vein compression.
Well, it's not only in my mind, it's what the scientific evidence shows. Styloid process itself may be source of irritation for the carotid artery, and we know that there are many cases, it's very well known, it's very well documented, that the styloid process may cause compression of the carotid artery and irritation of the carotid artery that may lead even to strokes or transient ischemic attacks, so somehow disturb the circulation, the blood flow or blood inflow to the brain. And also styloid process is involved in this jugular compression when the C1 pushes the jugular vein and compresses it against C1. So think about the styloid process as a wall. As C1 pushes the jugular vein gets narrow and kinked, and in the last stage is pushed against the styloid process. If you resect the styloid process and the C1 transverse process, you will get the best results, no question about it.
So you don't leave like any chance behind.
Absolutely. You don't leave any chances of recurrence. You don't leave any source of potential compression there.
Mm-hmm. Also, as we see, Dr. Kamran, Eagle syndrome, it's common surgery in ENT department.
That's right.
And also head and neck surgeon can perform this type of surgery,
which is a subspecialty of ENT.
So you as a neurosurgeon, do you classify that, and what make you interested in this disease?
Well, here it is. The reason why Eagle syndrome is in a, let's call it, realm of ear, nose, and throat surgeons, because Dr. Eagle was an ENT surgeon. So historically, he was the first one to report this disease, and he basically discussed it with his colleagues, basically ENT surgeons, and they continued his work. But later on, as the disease progressed, we figured out that yes, the Eagle syndrome, the classical version Eagle syndrome, has to do a lot with neck issues, like a pain in the neck, difficulty swallowing, pain in swallowing, the conditions we called dysphagia and odynophagia. So these are very well known in ENT specialty. But the most feared complication of the Eagle syndrome is vascular complications, when it interferes with the carotid artery and with the jugular vein, impairing blood inflow to the brain and blood outflow from the brain. And as you may think, brain is kind of important organ, allegedly. So that's why neurosurgeons and the neurologists should get involved. In my opinion, it's absolutely necessary for the neurosurgeons and the neurologists to familiarize themselves with this disease, because it primarily affects the brain, basically blood circulation in the brain, inflow or outflow. Another reason for the brain surgeons to get involved, as we discussed earlier, it's C1. So the main culprit, the main reason of compression is coming from atlas. And atlas itself is a specialty of spine surgeons, which is a subspecialty of the brain and spine surgery. So the field is called neurosurgery, which includes brain surgery and spine surgery. So that's another reasons for the brain surgeons to get involved. Unfortunately, there are not too many neurosurgeons involved in the care of Eagle syndrome. Most neurosurgeons do not know this disease or haven't even heard about this disease, which is unfortunate.
Mm-hmm. So in your technique or in your surgery technique, let's say, you always consist to remove both of them, styloid process and shave C1. Yes,
that's right.
To do decompression of IGV or internal jugular vein. So that push people or the patient who had this disease to ask many questions, more questions than standard one. Does it affect on the neck movement or stability of the neck? So these questions lead us to ask you about it. What is your opinion about that?
Well, first of all, I would like to say that opinions are good. Okay, you may have an opinion about this and that, but in order to answer these concerns, you have to look to the data, to the scientific evidence. And this is a question that we see all the time. The people come from all over the world, and the main reason why they ask about this C1 induced, C1 resection induced instability, because the ENT surgeons they have met previously, they basically talk about the removal of the styloid process alone without touching the C1. And when we talk to patient about removal of the part of C1, the first things that pops up is, well, will it induce any instability in my neck? So to answer this question, we have to look at the data. So first of all, we have to look at the anatomy of the C1. So C1 is a ring-like structure. So it's like a closed ring, and the transverse process is the part of the C1 that we are removing. These are kind of a small wings that protrude sideways from that main circle or the ring. It's very important to notice that these transverse processes do not contribute to the stability of C1. They are not the part of the C1 involved in a stability of the C1 in regards to C2 or skull or any other structure. They work primarily as attachment point for some small muscles, which, by the way, attach to other bones as well. And there is no data that would indicate or even point out that removal of these transverse processes can lead to any instability in C1. So there is no precedent in medical literature, and this has been done for a long time. And I would like to remind you that C1 transverse processes has been removed for a long time in neurosurgery, and there are lots of cases historically, but no such a case exists when C1 transverse process resection led to instability. When we do, for example, surgery for Chiari malformation or for tumors inside the posterior fossa, we sometimes remove the part of C1 that we call arc. That part has to do with the stability of C1. Even that do not lead to instability. Sometimes we resect the deeper part, or the part of C1, we call it the lateral mass. And it's considered that if you remove 1/3 of lateral mass, the C1 stays stable. If you remove more than 1/3, let's say 2/3 or 3/4, then C1 may become unstable, then you need to stabilize it. So from stability standpoint, transverse process are the least concernable points. They can be safely resected without contribution of instability. And I've done many of these procedures. I've never seen in my practice instability as a result of C1 shaving.
Sometimes we hear about Stent, like as a treatment. It could be also, or how do you think about it?
Well, here it is. We have a similar condition. So remember on last podcast we talked about the thoracic outlet syndrome. And the thoracic outlet syndrome has its variants, venous, arterial, and neurogenic thoracic outlet syndrome. And Eagle syndrome, or atlanto-styloidal compression syndrome, also is like this, because in this area in between C1 and styloid process, and in the vicinity of this area, there is carotid artery, there's a jugular vein, and there are a bunch of nerves like number 9, number 10, number 11, and number 12. So glossopharyngeal, vagus, accessory, hypoglossal, and sympathetic trunk, which is nearby. So there are lots of nerves. So this area is densely packed with nerves and vessels. And compression may affect not only the internal jugular vein, it may affect the artery or the nerves in a various combination. We don't have classification like in thoracic outlet syndrome clearly showing that there is a venous version or arterial version or a neurogenic version, because Eagle disease or Eagle syndrome or atlanto-styloidal compression syndrome, it's at early stages. So it hasn't maturated it yet. We don't have enough data for that. But we do know that there is a significant nervous component to it. However, having said that, sometimes the stent therapy that they suggest as a treatment option for the jugular vein compression, exclusively for jugular vein compression, has no chance of helping the patient, and I'll explain why. So, as we told, the jugular vein is being smashed between two structures, two rigid structures. Number one, and the most important, is C1, transverse process, pushing the jugular vein forward, and then number two, styloid process, which stays steady and acts as a wall against which is pushed. So two bone structures are pushing internal jugular vein externally, that means from outside. So how does a stent work? So stent is basically a network of metallic wires, and it's in a collapsed state. So you pass it through the narrow segment of the vessel, and then you put a balloon and you expand it. And because it's a metal, it expands and stays expanded. All right, great idea. However, it will work if there is no bones around, because stent and balloon that is expanding the stent cannot expand it and force it to push the bone away.
You mean it doesn't have that power to push
No,
that
it doesn't have
wall,
that
let's
force.
say, like that wall.
It does not have that force. If it has that force, it will break the wall or rupture the wall of the vessel, and that would be a disaster. So it doesn't have that much force. So what happens? Let's say you slip the stent inside the jugular vein, and in between these two bones, let's say you managed it, and then you slip the balloon inside it, and now you're expanding and you're trying to inflate the balloon. What happens? The part of the stent that goes and hits the bone, it cannot expand any further. So what's happening, the parts that are in a soft tissue, they expand, but they are not compressed. So you're hurting the part of the vein that is not damaged. And that basically not good. Another thing is, as the stent cannot expand in between those two bones, so the stent has no meaningful value. Okay, so it will not expand the jugular vein, because another reason to avoid stent therapy, because it ruins your surgery. So let's say you pushed the stent inside the jugular vein and you expand it, it did not open the jugular vein, but it stays there. So it's a rigid structure. And with time, stents becomes a part of the wall. So now if you go and do surgery, adequate surgery, resect the styloid process and resect the C1, the jugular vein cannot expand because it's not elastic anymore. Okay? So you basically ruin your chances of recovery with surgery in the future. So stents can work only if and only if the styloid process has been removed, the C1 has been removed, and there is a residual narrowing there.
Or a clot, like
Or
a blood
clot, or a
let's say.
residual narrowing there caused by the soft tissue. In that cases, stent may have
So
some
you mean
value.
stent after surgery, after removal?
Could be used if there is an indication for that. But if surgeon comes and relieves external pressure, in most cases, in the 99% of cases, there will be no need for the stent in the future.
So, and what about other methods? For example, we see some doctors, they use from cheek to behind the ear, the scar, I mean, or the incision, surgery incision. Sometimes they enter from the neck area or cervical area, and sometimes from mouth. We talk about mouth because Dr. Eagle, but what about your technique?
Well, here it is. As I said earlier, the Eagle syndrome or Atlanta styloid compression syndrome has been a condition that stayed in a realm of ear and nose and throat surgeons and head and neck surgeons by their extension. Unfortunately, for the most part, they have been focused only on styloid process. They haven't been focused on the jugular veins. They haven't been focused on the carotid artery. They haven't been focused on nerves in the vicinity of the styloid process, and that lead to the problem, because historically we have lots of reports, treating Eagle syndrome, which is solely focused on the removal of the styloid process. Listen, it doesn't matter what the techniques that you use, what is your approach. What matters is what do you do actually during surgery. So in order to have adequate solution to the problem, you should eliminate the root cause of the problem. In this case, you should take off the part of the C1, which is, by the way, safe to remove, that is causing the main compression. And ENT surgeons, because of their education, because of their training, are not trained to do so. That's why we have this discrepancy when the ENT surgeons, they go focus solely on the styloid process but pay no attention to C1 at all. When I do surgery for Eagle syndrome, because people call it Eagle syndrome for the lack of better word, as I mentioned earlier, it should be called Atlanta styloid compression syndrome. My primarily focus is C1. I also resect the styloid process, but the primarily focus is to remove the C1 as a primary source of the compression. And even after that, if you resected the C1 and the styloid process, there might be still residual compression there from the nearby muscles. And in those cases, I go and find those muscles that are pushing the jugular vein from behind, and I remove pieces of muscles to have full decompression of the jugular vein. It's also important that the muscles can also compress the jugular vein from behind.
So, for example, when the patient come to your clinic, and after you do a diagnosis and so on, when you say this patient needs surgery, in which case you decide, or when you decide to do surgery for the patient?
Well,
Is it always like standard, or there is symptoms we should focus on it? Please.
so here it is. Okay, the people may have various symptoms. So some of the patients, and these are minority of the patients, come to clinic, come to office with specific symptoms that are related to styloid process and styloid process only. You can say that they basically have symptoms like a pain in their throat, in their neck, when swallowing, or even without swallowing. They have difficulty with swallowing, pain somewhere in the upper, the neck area behind the jaw or lower than jaw. Okay, that may shoot into the jaw or teeth or face. So these are the group of patients, classically described by Dr. Eagle in his manuscript. Another group of patients are different. They come with compression of the jugular vein. And these are the real issue, because these patients may not have any symptoms related to elongated styloid process.
Even swallowing and so.
Yes, they may not have swallowing issues at all. They may not have the pain in this area. They may not have facial pain or the typical stigmata for. They may not even have a long styloid process. Because when it comes to jugular vein compression, the length of the styloid process, it doesn't matter. Only thing that matters is the distance between the styloid process and C1. So styloid process might be normal, but the distance between styloid and the C1 might be narrowed. So these patients may not have any symptoms regarding swallowing or eating or neck pain whatsoever, but they have distinct symptoms related to the compression of the jugular vein. And those symptoms include headaches, particularly headaches related to the position. So they feel headaches is getting worse when they lay down. And the reason for that is when the jugular vein is compressed, the flow is obstructed. So the blood cannot flow through this pipe. And when we're standing or sitting, gravity somehow helps to pull the blood inside the jugular vein down, and helps a little bit. But when we lay flat, there is no aid from gravity, and that's why the blood gets stuck or accumulated in the brain, which leads to increased intracranial pressure and resurface of the symptoms. So they have headaches. Headaches usually associated with the feelings of pressure inside the brain. They typically mention there is a pressure inside my brain. That's typical. Sometimes the pressure may go so high, they may have visual problems. Blurred vision is quite typical for high intracranial pressure. Sometimes they have, most of the times, they have tinnitus. Voices or noises in their ears. We don't know exact reason for tinnitus. It might come from two sources. Number one source is a turbulence inside the internal jugular vein when the blood flows through this narrow segment and basically circulates and causes the vortex, which leads to the acoustic waves that are perceived by the ear, or increased intracranial pressure may itself cause tinnitus. It's a very well-known side effect of increased intracranial pressure. Another set of symptoms related to jugular vein compression and increased intracranial pressure are the so-called, I call it scholastic symptoms, inability to perform scholastic functions, functions like mathematics, functions like problem solving, or intelligence that require quite high level of intelligence. These people constantly feel the conditions I call the foggy brain. The brain is kind of foggy. They cannot concentrate on anything, and the intellectual functions suffer as a result of chronic intracranial pressure, hypertension.
So when you diagnose this disease, what is the best scan to go through it, or best way to diagnose this Eagle syndrome? And how you know, like, Eagle syndrome, about styloid process exactly, and about jugular vein compression. So there is a little bit different, as I understand from you. And sometimes we see also like there is alternative way of blood flow and so on. Which one you follow it first?
Well, the most useful, practically speaking, test for Eagle syndrome and atlantostyloidal compression syndrome is CT venogram of the neck.
Cervical CT.
Yes, cervical CT venogram. It includes a part of the brain, but mostly it shows the veins of the neck. And particularly, we're interested in the upper neck area at the skull base, in a region of C1 and the skull base. CT venogram shows the vein, the narrowing of the vein, if there is any narrowing, the length of the styloid process, the configuration of the styloid process, the configuration of the C1, and everything that's happening in between. So it's actually a very, very nice initial test for the diagnosing, the kind of suspecting the condition. If you have strong clinical evidence pointing out to increased intracranial pressure, that test alone may be sufficient to proceed with treatment. In disputable cases, in cases when there is a kind of a vague discussion, okay, whether it's a compression or not, what you can do, you can measure the pressure at the various points of the venous system. So you can put a catheter inside the jugular vein and measure the pressure inside the jugular vein below the point of compression, above the point of compression, and above and above and above, whatever it is. And if you find the gradient, the difference, above the narrowing point and below the narrowing point, we call it gradient. That's a sign that the blood has hard time passing through the narrowing segment. That would be another evidence to help to diagnose this disease. But this test is invasive test, and it's not performed in any center, so there are specialized places that do it. As I said earlier, in most cases, CT venogram plus very strong clinical suspicion may be sufficient to diagnose the condition. And also what we actually figured out, that when there is a compression in the jugular vein, particularly if the compression is bilateral, means that on both sides, so left and right jugular veins are both compressed, the blood finds alternative way, or we call the collateral way of passing through, bypassing this obstruction area. So instead of going into the jugular vein and then back to the heart, it goes into the area we call the vertebral plexus, in the area of C1, or the area between C1 and C2, and then further through the back portion of the neck, back to the heart. So, and that's collateral circulation. So when the major pathway is closed, the blood flows through the collateral. And one of the interesting things that we observed that when we do surgery and when we remove the obstruction, the collateral network disappears, which is an indicator that we resected the bone enough and we expanded the jugular vein, and the jugular vein is like a straight pipe and the blood flows into it vertically like in a waterfall, and then there is no reason for the blood to go through the alternative way, and we see that the collateral circulation has vanished. In some cases, we can see it right after the surgery, next day after surgery. We do CT venogram, and we see that the collateral is gone, that it's not there anymore.
Nowadays, because of social media and all the diseases group and so on, we see sometimes there is like group of people talking about vagus nerve. Is it part of this disease or it's far from it?
We don't know. We don't know because right now we don't have very reliable tools clinically and radiologically or any methods to diagnose the vagus nerve compression or vagus nerve dysfunction. Okay, it all comes down to clinical suspicion, but we know that the clinical suspicion might be misleading. Okay, so we don't really have very good tests to confirm, and that's a problem and that's also a problem with the thoracic outlet syndrome, as we spoke last time. So, for example, in thoracic outlet syndrome, we said that 90% of TOS cases are neurogenic, but we don't have the nice, reliable tools to diagnose it. In past, they used the EMG to diagnose the thoracic outlet syndrome. We figured out that the EMG is a useless test. Okay, it does not pick up this disease. There are some elements of EMG can be used and believe me, EMG of the brachial plexus or the nerves of upper extremity is much easier, incredibly easier to perform than the EMG of the vagus nerve, which is unheard of. So the point is, we don't have really good tools to evaluate the vagus nerve. So right now it's a shaky ground, and some physicians or self-proclaimed physicians, they use this term quite broadly. And the same goes for the atlanto-occipital or atlanto-axial instability. We see kind of an epidemic of so-called craniocervical instabilities, where it's not instability at all. It's just people are just being operated on a very vague backgrounds. So there is not reliable tools to diagnose these conditions.
Okay, because why I'm asking that, because we see on that group, some of your patients before the surgery, they have symptoms like stomach problem and this stuff, and after the decompression surgery, Eagle syndrome and jugular vein, they say these symptoms disappear. So that's what I'm asking.
Well, here it is. It might be. The only way we can talk about is in a retrospect. If you do surgery, if you do adequate decompression, and the patient's symptoms go away. So retrospectively, you can go back and tell, okay, so it's very likely that these symptoms were caused by the compression. And it might not be the vagus nerve. It might be the sympathetic plexus, which is basically in the vicinity of jugular vein and carotid artery in that area. Okay, so very frequently I hear symptoms like palpitations or a fast heartbeat. It comes out of nowhere, And some patients go and get evaluated by a cardiologist, and they get treatment sometimes for palpitations or tachycardia or paroxysmal tachycardia or whatever they call it, but it goes away right after surgery. And that might be related not to the irritation of the vagus nerve, it might be related to the irritation of the sympathetic trunk that is nearby. But this is all the areas or the symptoms that are kind of vague and undocumented. We don't have a hard evidence indicating. We have some soft evidence, but it's not very hard, it's not very settled. So when I speak to my patients, I always mention that there is no hard evidence indicating that this set of problems related to the problem, to the compression there, but very likely to originate from the compression at the C1 and the styloid area.
Thank you so much. This has been very informative. Before we close, what message would you like to leave for patients or doctors who are listening to us today?
Well, for doctors, it's going to be a completely different message. For the patients, completely different message. For the doctors, I would recommend to familiarize themselves with the Eagle syndrome or atlantostyloidal compression syndrome, okay? There are excellent review articles and excellent papers regarding that, so you can familiarize it. There are even there is a book related to the Eagle syndrome. It's just called Eagle syndrome, okay? They can familiarize themselves because knowing the disease or the syndrome will help them to suspect and treat, or at least to refer the patient to the specialist. So knowing is a power, knowledge is a power. And also knowing how to apply that knowledge is also a power, maybe a bigger power than the knowledge in the empirical knowledge itself. For the patients, there are very nice online sources of information. I'm afraid to say that, but the truth is, in the vast majority of cases, patients make the diagnosis by themselves. They go to doctors, the doctors basically say everything is normal to them, they keep searching, and in vast majority of cases, patients self-diagnose the problem, the condition. And there are groups, as you mentioned, where they can be part of the group and communicate through the groups. And surprisingly, lots of patients with this condition, they know about this condition much more than the doctors and the professional doctors do. So most information for the patients are in internet, basically through the social groups or through the websites.
Thank you, Dr. Kamran, for this detailed explanation. It was an honor to have you with us.
My pleasure.
Thank you.
My pleasure. Thank you.